Good afternoon. Welcome to the Daily Dose of Dopamine. My name is Robert, and I'm here with my pal Benzi. Dr. Benzi Kluger, how are you, my friend?
Hey, doing good.
So we've been
Good.
talking about doing this for a while, but life and coordination sometimes makes it a little bit of a challenge. I see we're both wearing blue. We're both, peppered, and salt
Yep.
and pepper bearded. So people are going to think we're really, we're close, man.
Yeah.
Well,
Coordinated that. Even coordinated our meals today.
we did. We
Spaghetti.
both had spaghetti. Now we're on opposite coasts, of course. You're up at now you're at Rochester, correct?
Rochester, New York. Yep.
And how long have you been teaching? You're teaching and researching, I imagine there, yes?
Yeah, my main yeah, I'm a professor there. Majority of my time is research. I see patients on average a day a week and squeeze teaching in between. Actually, we could talk about this more too. We just got a pretty cool grant. Actually, you would appreciate it. It would have been one that you might have, or maybe you would still pursue. It's a postdoctoral training grant. So people who have either finished their clinical training or have finished a PhD in a research area and have a heart for applying the biopsychosocial model.
Oh, wow.
In other words, taking a whole person approach to helping older adults with serious illness. And we purposely made it very broad because we wanted to help connect people who had big hearts and big ideas to
Mhm.
get the kind of rigor they need to change the world.
Wow. Yeah, you're sounding like you are talking to me.
Yeah.
So let's break down that biopsychosocial whole person model thing. What does that mean, and why is that important in medicine?
Yeah, the biopsychosocial model actually was developed at the University of Rochester, or at least the term was coined here by a guy, George Engel, in 1977. And at that time, and I think it's still true today, the dominant paradigm in medicine is what's called the biomedical model, which means that if we take an illness like Parkinson's, that what's important is happening at a biological level, that it's all about alpha-synuclein and dopamine and neural networks, and that treatments are all about surgeries to change physiology or medications to change pharmacology, and that anything else is maybe icing on the cake. And George Engel said there's a problem with this model. There's no people in it, and there's some important things that are different between trying to treat a body and treating a person. And that runs a whole gamut. I know you've been interested in prevention, which gets into kind of the larger societal aspects of illness and how poverty and racism and other things, that's not part of the biomedical model.
Right.
But those things are all very important and they affect not just who gets ill, but how they're treated and how well they do after they're treated. It has to do with things that are very near and dear to my heart, which include not just anxiety and depression, but also people's normal emotional reactions to having a crappy illness. So things like grief, anger, frustration, guilt, demoralization, which again are important not just in terms of symptoms, but they're important in terms of how people do over the long run and how motivated people are to take part in their treatments, how well they do. Um, and the last part of the model that I think, so there's a bio part, there's a psycho part, there's a social part. And George Engel also articulated, which I think is important, that medicine is relational, meaning that it's done between two people, and how those two people communicate is an important part of the medicine and the treatment. And again, that goes both ways. And so, if I have no bedside manner and I'm kind of a dickhead, um, I'm often going to get the wrong diagnosis because I'm not listening to important details that you're trying to tell me and that you're not feeling seen and heard. And the flip side of that is that if I'm not, again, don't have that compassion, that skill set, that ability to communicate, there's going to be parts missing from the treatment plan. There's going to be things that are unaddressed that may be important. So I think it's an important approach, but it hasn't really been fully actualized.
Yeah.
You
So
know,
two parts here. Number one, give me some insight on who George Engel is, when he came about with all this. And number two, where do I sign up?
yeah. So George Engel, I'm actually learning more about him, and I can tell you about another project I'm up to. But he was an internist
Mhm.
And I think his early research, he got very interested in things like fainting and what's called psychosomatic medicine. So symptoms that kind of fall in this borderland between the psychological and the physical. And he and another researcher, John Romano, came to the University of Rochester, became head of their psychiatric department, and he spent a lot of time developing it from. I've never met him; he died before I got here. But from talking to his students, he was just an amazing diagnostician and amazing in communication. And he would walk into a room and get patients to tell him things that they've never told anyone else before. And because of that additional information, be able to figure out what was going on at a level that no one else had figured out before. Um, and so that was really central to him and has actually become central to the University of Rochester. The University of Rochester's got a reputation among medical schools as being a place, it's almost like the humanistic medical school.
So
And
I mean, it sounds like better care by
Mhm.
better relationship. That, in other
Yep.
words, your role as clinician is not just to know things and be able to view things, it is to relate in order to help elicit, because some of that information, as you're saying, isn't going to be found under a microscope or through a blood test or any other type of battery. It's going to be found from the human being who him, or her, or themselves. They may not even understand the wisdom or brilliance of what it is they're saying, what they might be unlocking if
Mhm.
given the right way to unlock it. Is that, am I in the ballpark?
Yeah, yeah, that's a big part of it. The other part of it is that the relationship itself is therapeutic.
Mhm.
And I'm trying to remember the name of the author. There was a book written a while ago that was about medical friendship, which may sound a little bit odd. But this individual was kind of charting the history of medicine and kind of following these parallel paths of what's been called the art of medicine,
Mhm.
which is about, essentially the human side, and the science of medicine, which is the technological side. And he names this thing, which I really relate to. You can see if it relates to you as well. But he said when a doctor or surgeon or whoever performs their technological task, well, you feel a certain level of gratitude. But when they connect to you as a person, when you feel seen and heard, when you feel like you have a companion on this scary journey, uh, that goes beyond, this kind of transactional thing. And he uses the word friendship. I might use the word love, actually. Carl Rogers, I think, used the word unconditional positive regard, but that there's a level of caring that I think is invaluable. And when it's there, you know it, and it gives you hope, and it makes you feel safe. And I think it helps you on that process. And when it's not there, you feel very alone, and it's a kind of a scary place to be.
I'm guessing the word love is not taught much in medical school.
It's like a four-letter word.
So why?
That's a great question. I've been thinking about that myself. I gave a lecture so going back to George Engel, I was invited to give a lecture. It was our annual George Engel Memorial Lecture, and so they invited me to give it. And as I was preparing for it, I was thinking about the biopsychosocial model, and I was thinking about what was missing from it and how maybe I would do it differently because there were things that didn't sit totally well with me. There were things I love about it, and I think it was a huge advance. And at the same time, there were things that I felt could be done even better. Um, One of the things that's missing is spirituality. So that was not named or mentioned or at all part of the biopsychosocial model. And so there have been people who have proposed a biopsychosocial spiritual model, so just adding like a spiritual appendage to this whole thing. And that wasn't totally satisfying to me as well. And so as I got to thinking about it more, I was thinking about the shape of this model and where is the center of the biopsychosocial model? Is it a molecule? Is it an atom? Like where is the person? And essentially the person in this model is it's a materialist reductionist model. I mean, so there's psychological parts, there's social parts, maybe we could add in a spiritual part, but it's a collection of parts. And to me, when medicine is done really well, I'm one soul sitting in front of another soul, what I would call an embodied spirit, and that there's a part of a person that cannot be reduced. And to me, that's what I would call the soul of care or the heart of medicine. And then from there, I would use the word love to describe the relationship. And when I'm practicing and I'm really in the zone, there's two souls in a room and there's love between those two souls, and we're working towards healing. And then the last layer I would put on this model is society. And so thinking about society, not just in terms of how it may cause disease or not cause disease, but thinking about society as a potential place where healing can happen. So kind of moving away from the model that it's only in clinics and hospitals that healing and medicine happens, but also that it's bidirectional and that, I feel like part of our society's, demoralization, search for meaning is the separation from healing. And that there's the potential not just for people living with serious illness to get better care if the people in their community get that. And we can talk about there's a movement called compassionate communities that's all about how do we help people in the 99% of the time that they're not in clinic. For example, having movie theaters that are friendly for people with dementia, of having restaurants that are better geared to people living with serious illness, et cetera. But also that there's a potential that there would be healing of society by involving everybody in healing. So that's kind of my long-winded answer to why I think to me love is such an important part. To me, I feel like it's a bedrock of good medical care.
Right. Yeah. If you start from there, if that becomes your center point, as it were, what grows out, and traditionally, just like you're thinking it in the garden metaphor, great soil, good placement with the sun, you're very likely to have your seeds do better. The idea of the dementia-friendly spaces, have you seen or heard of these places? I know somewhere in Scandinavia, I saw a video that they have a village.
Yeah.
Yeah, and all the people working there are medically trained. They are the cashiers, etc. However, they are there to kind of keep it up an almost Truman Show-like, facade for the people with dementia so that they never feel disconnected from themselves, regardless of where they are. Everything's basically yes anded.
Right.
So you've heard of this as well?
Yeah, I have. Yeah, a friend of mine who you may want to have on the program at some point. His name is Al Power,
Mhm.
but he's a geriatrician, but he goes around the world helping nursing homes, helping clinics, helping other people. He's developed a model basically based on Maslow, which is that we care for people with dementia by focusing on their well-being,
Hmm.
which is a totally different model than that we're focused on controlling their behaviors.
Yes.
And so, like the Scandinavian and other examples is one model. I mean, that's one way of doing it, but there are other big and small ways of focusing on well-being. And the hypothesis there, which I think is true to a larger degree than many people would want to admit or realize, is that when somebody living with dementia has their needs met, the problem behaviors decrease.
Yeah.
As opposed to the biomedical approach. This is a great example, actually, of a difference between a biomedical and a biopsychosocial. The biomedical would say, this person's agitated because of changes in brain chemistry.
Right. So,
Whereas a one biopsychosocial lens could be this person's agitated because all their life they've had purpose and now they have no purpose. And they're trying to figure out what they're supposed to be doing.
yeah. Yeah, you're not going to solve that with a pill.
Right.
Yeah. Yeah, purpose is more than a pill. There's something to that. The There's a phrase that came out, we saw each other last at the World Parkinson Congress, and you were kind enough to come to third base, which I'm going to ask you about in a minute. But after the World Parkinson Congress, I immediately went to ATMRD there in Washington, D.C., and gave a presentation with Dr. Indu Subramanian. And the framework for it was based on some research I've done with support group leaders and support group attendees. Did I fill you in on some of that?
I don't think so. Yeah, go ahead and
So the
no.
basic scope of that was with PMD Alliance was looking
Yep.
at what makes support group leaders and attendees, how do they feel about their groups, from their importance to how they're functioning to where the deficits are? Broad scoping set of questions. And what came back in the first set of research, I think we had about 500 people in the first set of data back in 2024, was, yes, they value them highly. They see them as incredibly important. They have a lot of the same problems in terms of, the one person who talks over, or how often to run groups, or, what style to run. The biggest surprise that came out of it was the disconnect they felt between their local healthcare provider and the support group. In other words, it not being recommended, sometimes not even being known,
Mm.
certainly not
Yep.
being, supported in the
Right.
sense of showing up, right? And I mean, the number was like, it was in the low 30s, 30% of those who felt they had that good relationship. And so the second part of the research, we ran the study again and got similar numbers with another 600 in the spring here. Second part of the research was supposed to go into interviewing the healthcare providers to say, so here's what we found. What are your feelings about support groups? Because it's a blind spot, right?
Yeah.
We don't know. We've heard anecdotally some things that people feel
Yeah.
about them. Unfortunately, PMD Alliance lost their funding. So we have this great survey ready to roll, but we don't have funding for
Okay.
it. And, would love to do it still, hope to do it. But what came out of it for sure, similar to what you're talking about, was this phrase that all of a sudden has become kind of my guiding force, which is, we know in Parkinson's that exercise is medicine, is
Hmm.
an incredible thing, right? That exercise is no longer a good idea. Exercise is medicine clinically, is massive to getting compliance, to getting buy-in.
Yeah.
And that's only happened in the last 15 to 20 years. But now it's, yeah, everybody says it. Uh, Similar to what you're saying, connection is medicine,
Yep.
is what I gave the talk with Indu about. She really liked it. And I've been running with it ever since. And the feedback's been excellent. That you obviously get it right away. But
Mhm.
the power, what do you feel about the power of being able to adopt the idea that connection is medicine? What could grow out of that?
Yeah, there's different layers to it. I'm trying to remember. I could look up. There was a gentleman who gave some talks. He's from Pittsburgh. I don't know if you know him. He gave talks at the Davis Finney Foundation, who introduced me to this idea of social capital.
Okay.
And that was a very influential idea for me. And he talked about how, with an illness like Parkinson's, you're not hanging out with the people you used to work with. You're not doing the racquetball club. You're not doing X, Y, and Z, and your social capital can shrink. And that when your social capital shrinks enough, it's the same health risk as if you had taken up smoking.
That's right.
And so that was the first time I had heard that. In the last Surgeon General also recognized that social isolation is a pandemic,
Right.
and so there's the flip side of that, which is that lack of connection is harmful. And so it stands to reason that social connections are necessary, and as you say, I mean, are therapeutic.
Yeah.
And it is something that I think about a lot in my work. And I would say one of the joys of our clinic, we can kind of talk about more what we do in we have a neuropalliative-care clinic, which is very much run on a biopsychosocial model. And we have chaplains and social workers and nurse who are part of our team.
Mhm.
But one of the parts of my job that is like amongst the most heartwarming is getting people reconnected to their community, and finding that they have more help and more support around than they might realize. And that can involve getting people to reconnect with their church. Oftentimes, those people are looking for opportunities to do good and to help. And so, rather than it being an imposition, it's a gift to be able to say, hey, I'm, part of this, I was part of this church. I haven't been able to go to mass for the, last year because of my Parkinson's. And, do you think you can help? And then there's this amazing connection that happens. I had a gentleman, I think it was about a few months ago, who was a beloved high school lacrosse coach. And similar thing where, he's no longer able to coach, but he can still sit in on the practices, could still be part of that community, could still be part of that circle. And again, there's this, amazingly rich network of support and purpose and meaning and gratitude that we don't think about, but that people can tap into.
I love that. That idea of connection with gratitude and the way the network comes together. You mentioned earlier the idea of spreading healthcare, or I may have just interpreted what I heard you say, beyond the typical hospital walls, right?
Yep.
I long had an idea. I don't know if I got it from someone or it's just something that sat with me of what if we had medical and all kinds of medical opportunities the way we have Starbucks. You know what I mean? On all these corners that, especially in an AI world where if people are feeling devalued in so many other job spaces, what if our jobs became to be connectors, relationists to a degree, facilitators, to basically help people feel your job is to help people feel seen, feel, and heard. Um, I mean that could be a real job. And just the way you'd serve someone coffee, you're serving someone a conversation, you're serving someone a relationship. I mean, does
Mhm.
that make sense?
Yeah, yeah, it does. There's a project, Sandhya, who you know, Sandhya Seshadri. I don't know if she's been on your show or if you'd want to have her on at some point.
Yeah.
She's been working on a project that we learned about, started in Memphis. We learned about it in Indianapolis called Congregational Connects. And what that program is all about, and we're trying to get it started up in Rochester, is to train volunteers at churches or synagogues or mosques to be exactly the person that you're talking about.
Yeah.
And in Indianapolis, which has an amazing spiritual care program, University of Indiana, um, chaplains are in primary care offices and ED and hospitals. And if they find somebody who is isolated, lonely, at risk for poor outcomes because they don't have social support, they'll partner them with a Congregational Connect volunteer. And it's worked amazingly well. And it's great because it's like it's kind of a low time commitment, high payoff for the volunteer. It's worked well. Yeah, it's an amazing win-win situation. So
This is the part people miss a lot in the exchange you just mentioned is how much the person you said win-win, yet I don't think people they focus on the person being helped, as it were, identified. The person who gave, who received purpose from giving, gets just as much, if not more, than the person who was, helped or saved. Absolutely. And I see this tangibly in my uh, improv space all the time because we there's a phrase that we say the person who gives the most wins, right? And that idea is to make the other person look great. In a sports analogy, it's dishing the assist, right? And people who come into my classes, they often do, maybe in a bad mood, things that day hasn't been going well. They're sometimes my favorite, and I make sure, we let people say, come as you are, and let's declare. We start with a phrase like, I feel, and they can say, I feel like shit. And we're like, thank you. Awesome. Thanks for saying that. I'm not happy you feel like shit. I'm incredibly grateful that you were vulnerable enough to say that. When that person starts playing and they yes and somebody else, somebody says, I want to go pick blueberries. Yes, and let's go out to the forest to do that. All of a sudden they realized I validated their idea and gameplay, and we created this thing by mirroring, by affecting them. They didn't need anything
mhm.
except to yes and to reflect, to mirror what that person gave them. And they feel so fulfilled that they helped another person.
Yep. Yeah, for sure. I think one of the things that's heartwarming about this, and like I have a unique perspective on, is that there's not only does the other person feel good, but I think there's a deep hunger that people have to help others.
Agreed.
And people have this desire, and I think particularly in our society, in our world, the way it's set up right now, we don't have regular opportunities. Most of us don't have regular opportunities.
Or they're not rewarded at a high enough
Yeah,
level, right? They're,
right.
in fact, they may be denigrated. You may be thought of as a fool or a sucker to do that sort of thing.
Yeah. So it's I mean, people can still do it, but it's not the same as a very rich community or a rural area America or something where everybody's got each other's back as neighbors and things like that that were increasingly isolated. And yeah, I think. just people light up at the opportunity. I think I remember, and I'm sure you do as well, like in the early days of COVID, I think people were very excited about the potential they had to help other people.
Yeah,
And,
absolutely.
and I was as well. And it's interesting to see how that's, kind of melted. I mean, I don't know
Yeah.
about you. I'm kind of an idealist and a possibilist. And I was wondering, like, is this a turning point? Like,
Yes,
are
very
we
much.
gonna, are human beings going to get their shit together?
Yeah.
And it's like, no, just kidding.
Do you remember it was one of my favorite things media-wise that came out at that time? The actor John Krasinski, most known as Jim from The Office, but he's done, he's Jack
Okay,
Ryan.
yep.
He had this show, and his wife's Emily Blunt. I think it wasn't Life is Good. That's the Boston company. I love their work too. But it was something like that, Good News or something in the
Yeah,
way.
yeah, I
And
remember.
he was
Yeah.
doing this thing from home, right? And sometimes involving his wife or zooming in Steve Carell and friends or whatever. But then he was featuring the news of the day of the way people, were helping each other, just like what you're
Right.
talking about.
Yes.
It was so lovely. Did you happen to catch it? I mean,
Yes. Yes.
that was one of those, oh my God ideas. Like, where did that go? Right?
Right.
Because just because we are in crisis doesn't mean that's the only time we can treat each other that way. In fact, I mean, I wonder if anyone has, since we've gotten back to normal, whatever that is, even tried to pick something like that. Maybe we're far enough away now, from the true crisis center of it to where we can look back and start to measure, go, there were some good things we left behind that we would do well. And obviously things are difficult within current political climate. We don't have to go into all
Right.
that. But with the right set of people and the right, you know, type of ideas, we often do that. We find value in the things we left behind because we're running so far ahead, right?
Mhm.
Crowd dynamics. Gotta get. It's like, did you see what you just dropped?
Yeah.
In fact, I would point that out as one of my, I know that's one of my strengths. I've only worked a couple of real like corporate jobs in my life, and it's because I'm definitely the square peg in the round hole in those situations. But one where I excelled was this company where I was given a little bit of leeway from time to time to kind of see what I saw as, we'll call them societal disconnects within our company. It was about 75 to 100 employees, but I saw relationships being just left on the floor, opportunities to connect to clients or to in between departments and stuff like that all the time. And I would make videos or I would hold little meetings, and they were for a time period wildly supported. And oh my gosh, the idea that, and the way I visualized it was I saw these disconnected AV cords. I'm like, you guys just bend over and pick them up and
Mhm.
watch the energy flow. And it had a little bit of juice to it. Now it didn't have more than me to do it, and ultimately, the
Right.
the, the real numbers people got in there and weren't able to quantify it, so it went the way of the dodo, as did I. But I know that exists. That it sounds similar to what you're saying. The finding value. I don't know if you're at all a baseball fan, but do you know the book Moneyball or the movie Moneyball?
Yeah, about it. Yeah. Mhm.
The idea is undervalued assets, right? Through the lens of the movie and the book, it is, of course, certain statistical analyses within players and ways of, working the system to heighten success. You can apply that to people too. And again, it doesn't have to be clinical or cold in the way it's doing that. It's what are the data points of the people? What do we value of the people? The different things you've brought up as what could be seen of value, and how could we unlock those pieces of value within people that maybe have never seen them in themselves, or they've been crushed based on a
Yeah.
lifetime or, of that's not important or that's not okay or that's not valuable. Yeah.
Yeah. Yeah. With you. Yeah. Two thoughts come up. One, have you read the book, The Upswing?
I know of it, but no, I'm going to write it down right now.
Oh, okay. Yeah. The Upswing, yeah, probably one of my favorite books over the last few years that I've read in terms of being hopeful. But in essence, it tells the story of how, essentially a little over 100 years ago, at the beginning of the kind of the robber baron era, the the overall society and culture is actually eerily similar to today. Like some of the problems that I think of as distinctly modern were in existence then. And the analysis, I don't remember if the author is a historian or what a sociologist, what his background is, but across a whole number of different metrics, there's this bell-shaped curve, and they all are echoes of how connected, how much dialogue is there. And so, basically it makes the argument that the rise of America, up until the 1960s, was really driven in that there were preceding variables that had to do with connection, and it was the development of, bowling clubs and social clubs and, all these kinds of things. And so that was really kind of the fuel that created this greatness. And then the downslope was disconnection and increasing division and isolation and things like that. So the hope for me, at least with that book, is that maybe we will, get back, I guess we'll see what rock bottom is for society and the human race. Hopefully we don't die at rock bottom, but assuming we survive it, that we'll get momentum to start another upswing.
I love that phrase. We'll see what rock bottom is. It is, to me, a sort of a, I'm guessing you've read Hitchhiker's Guide to the Galaxy. You see,
Yes,
yeah, there's a little bit of a Douglas Adams hands off. Oh, well, we've done what we could. Thanks, goodbye. Thanks for the fish.
right.
Um, I'll tell you what, let's take our first break. We're 30 minutes into this, but I
Sure.
know we got more to say. Thank you very much. This is our first episode of Daily Dose. See you in a minute.
All right.